Thank you, Chairman, for the kind introduction, and thank you to ESCO and organizers, in particular, Dr. Albarai, for the invitation to share some of my thoughts on the potential future strategies in IBD care. So these are my conflicts of interest. The premise of this introductory talk is to gaze into the future and set the scene for the upcoming talks by my colleagues Jason, Brad, and David on various aspects of precision medicine and IBD. And I'm very much looking forward to their lectures, which I'm sure will do the deep dive in some of these areas of future IBD care. But I want to set out some of the strategies which I think may be applicable in the future. And I would like to propose that the future of IBD care will be based on 4 pillars, what I call as the 4 Ps: the prevention strategies, precision diagnostic strategies, strategies at precision risk stratification, and therapeutics. Let me briefly touch on each of these one by one. To me, perhaps one of the most impactful of all of these strategies will be preventive strategies. And why do I say that? We all recognize that there has been a rapid global rise in incidence and probably more importantly, the prevalence of IBD. And there are now well-recognized epidemiological phases that have contributed to the increasing prevalence of IBD. Although the incidence in the Western world seems to have plateaued, there remains ongoing rapid increase in incidence across mainly the emerging nations, the lower and middle income countries, which has large populations. And I think they will reach the similar equilibrium to the Western world, but the overall prevalence and the disease load across the world will be huge, which will put strain on healthcare systems. So in short, IBD has become a truly global disease with accelerating incidence in many parts of the world in yellow, particularly in Asia and South America in particular. And here you can see Egypt is also in the cusp of accelerating phase. And I know talking to colleagues in Egypt, they are seeing more and more IBD cases in practice. So this is why I think prevention will be a cornerstone in our future strategies. I believe in order to truly change that natural history and the long-term consequences of this compounding prevalence, both at individual and healthcare system level, an effective intervention should ideally occur at the early phase, what I would call as the preclinical phase of the IBD. Because by the time many of the patients have presented, they already have significant bowel damage and have uncontrolled immune response. So in many cases, it may be already too late. Hence, treating the primary biologic processes that drive the disease from an early stage, where we can impact on environmental factors before the disease initiation, may be more impactful in the decades to come. Is that really possible? Yes, there are already potential strategies which we can think about in genetically susceptible IBD individuals, using practical interventions on some of the potential triggers in the development of IBD, particularly in the pregnancy and early childhood stage. For example, the promotion of breastfeeding, reducing the use of antibiotics, and progressing research and understanding into the enteric and non-enteric infections, particularly the microbiome in IBD pathogenesis. Indeed, actually, preventive studies are already on the way. For example, the meconium study actually is looking at inoculating stool sample from mothers with or without IBD and their offsprings into mice, and then studying their immune profile and development of IBD to get an understanding of the pathogenesis and future preventive strategy. Another study from Mount Sinai, called the MELODY study, is using a dietary intervention during pregnancy in patients with Crohn's disease and those who do not have, and then evaluating samples from meconium and stool in the infants to get clearer understanding whether preventive strategies are possible in early life. Now, once you have developed the disease, to me, precision diagnosis at first contact is a key aspect of IBD care. Here I want to urge to get our basics right, and I was really interested to hear the previous case presenter who actually highlighted the need for early diagnosis. We do need to invest in this. We all know that even now there are unacceptable delays in diagnosis. There needs to be a strong push towards, understanding the disease process, increasing the awareness among primary care colleagues, and also from other generalists, and including patients. We should promote more use of biomarkers such as calprotectin, and as you heard just earlier, tools such as the red flag index. But that is now. But I think in future we will need to go further and be smarter to have a precision diagnostic approach in which right from the time when the patient knocks on your clinic door, incorporating not only just the standard diagnostic pathways such as the symptoms, blood markers, and colonoscopy, we should accurately determine the disease severity, perhaps include molecular endoscopy into that, and add to that genetic markers and cytokines and microbiota analysis to give a precision diagnosis in a given patient right at the time of presentation. And I think that will be the future of diagnosis of IBD. What about risk stratification? This is an important aspect in IBD care, and identifying patients who have specific disease patterns and lead to complicated outcomes during the disease course is an important aspect in IBD management. Currently, we use a number of clinical parameters to do this risk stratification, and you heard some of this in the earlier talk. Both in Crohn's disease and UC, we have number of phenotypic and perhaps one or two other markers which might help us in clinical risk stratification. And there are emerging tools which integrate some of these markers which can be used in bedside, such as this work from Corey Siegel, which looked at the various markers in which you can plot on the prospect tool and then come up with the risk of this particular patient who is in front of you in the clinic needing surgery, and thereby enabling you to stratify your treatment based upon that. But are there opportunities to further refine this precision risk stratification? Because even with these clinical risk factors, our ability to predict the disease course, as you saw in the earlier case, is somewhat limited. My answer is absolutely yes. In fact, there is significant advances happening in precision risk stratification, including a number of prognostic biomarkers and the development of genomics, particularly with polygenic risk scores and other specific risk scores, indeed aptly named as risk scores, which includes gene signatures in ileal disease. I'm going to pick up on one particular thing which we were involved. This was a seminal work from James Lee and colleagues in Cambridge, who clearly demonstrated by gene expression profiling of CD8 positive T cells that you can distinguish two separate group of patients with Crohn's disease who had different disease behavior when followed up over a period of up to 2 years. They took this further and developed a blood prognostic biomarker. This is now has already reached our clinics. And in this development study of the biomarker, they were able to distinguish two cohorts, those which they describe as IBD high and IBD low. And as you can see, based upon that differentiation, the need for escalation of treatment was able to be predicted. So we do have predictive tools which are being developed, and indeed this particular biomarker is being evaluated in the first ever biomarker stratified trial called the Profile trial, which is running in UK, which is enrolling patients with newly diagnosed Crohn's disease, doing their biomarker assessment before starting treatments, and then randomizing them up to either accelerated step up or top down therapy strategies. Now this trial is very close to completing recruitment this year, and we will be hearing the results of this in the autumn of next year. But I think what will happen in future is that we will need to integrate all of this to give adequate risk stratification power for each of our patients. So we will include not only the clinical parameters, but we will have a molecular stratification using the genome, transcriptome, microbiome, cytokines, and then decide whether the patient is going to have a high risk disease behavior in their lifetime, and that will allow us to tailor our treatment. What about therapeutics? It is suffice to say we have come a long way. In the modern era of biologics and small molecules, we have developed a number of molecules which have been added to our therapeutic armamentarium. And in fact, more are on the horizon. And if you just gaze forward to the next 5 years, you can see a number of newer molecules, including oral agents and more biosimilars, which hopefully will help in, realizing more patients are treated and there will be more equity in care across the world. But we are still having a big therapeutic gap. Despite all these advances, at best, most of our agents have 40 to 50% response rate and a remission rates which is even lower, roughly around 30% long term. So clearly there is a therapeutic gap, and it is crucial for us to identify and predict those response to therapies. Or can we actually predict non-response? The sobering news, however, is that we are not quite there yet. Our oncoming speakers will probably touch on some of these, but while there are a number of markers being proposed, many of them do not have sufficient accuracy to predict response or non-response, and some of them need further validation in independent cohorts. So in 2021 and 2022, how do we bridge this gap? Or indeed, how do we get more bang for the buck based upon what we have currently? This is where I think head-to-head studies, early treatment studies, which has given us some interesting results, and more importantly, what I think will be the future will be to take a leaf out of our oncologists to think about combination treatments, particularly combinations which involve a medium mechanism of overlap or medium crosstalk, so that we have a better efficacy rates with lower risk profile. Or even more attractive would be a complementary mechanism of action, such as combining a biologic with microbiome therapeutics. But I think the future strategy of IBD therapeutics would be actually not based upon individual agents. I think it will be based on strategies. So you will want to profile the patient as based upon their risk and risk of relapse and prediction of response to therapy, and then identify a target, which we already heard about the STRIDE guidelines, and aim for a dynamic approach to treatment, which will involve either sequential therapies or combination therapies. So as an introduction to our next three talks, let me conclude by saying that there are 4 P's which will become the foundations for our future IBD care. To me, the preventive care will be the most crucial among those. But precision medicine is making great strides, and the translation from bench to bedside is rapidly accelerating. Now, if some of them reach our bedside, I think the future of IBD care will be bright. Thank you for your attention.